Hello, everyone. Thank you very much for joining today. The webinar will start in about half an hour. Hello, everyone. Thank you very much for joining today. Please use the chat box to share where you are watching the webinar from. I will be so happy to know. And we will be starting in about 30 minutes from now, 37 minutes to be very precise. So again, thank you so much for joining. Please use the chat box. Thank you very, very much for joining us today. We will be starting in half an hour. Please use the chat box to share where you are watching us from and to share any questions. And the certificates will be given to you once you submit the quiz. I will be sharing the list to complete a quiz. And after you submit the quiz, you will be receiving your automatically generated personalized certificate. Thank you very, very much. Please use the chat box and share where are you watching us from. The webinar will be starting in about 25 minutes from now. Thank you so much. Use the chat box and share where are you from. Hello, everyone. Thank you very, very much for joining from wherever you are. Please use the chat box to share where you are watching us from. The webinar will be starting shortly. I will be sharing the link to a quiz, and upon submission of that quiz, you will be able to receive an automatically generated yet self-personalized certificate of attendance. Thank you. Hello, everyone. Thank you very, very much for joining today. Again, welcome everyone to this webinar. We will be starting in about 20 minutes from now. So please use the chat box to share your comments, your questions. If you got any thing to ask Dr. Professor Shroeder, then I will be able to take up all your questions at the end. And you will also be able to receive your own certificate once you submit the quiz. I'll be sharing a link for you to the quiz, and you can just submit the quiz and receive your automatically generated, customized, self-personalized, there will be name and everything on it, your own certificate of attendance. So again, thank you very, very much for joining, and please share where are you watching us from. Use the chat box, and please share all your questions and comments and everything. And also, please don't forget to visit the News New website. And there are new initiatives. I'm sharing you the web link that will be of your interest. I'll be really happy to hear from you and hear your suggestions. You can also email me I'm sharing my address. So here it is. You can share your comment or suggestions if there is any topic you wish me to organize a series on. So please feel free to email me and share what you want to listen to and to learn about. So I guess that the series will be good for you to attend, and you will be learning a lot, because I think neuroscopy is one of our great just new interest in neurosurgery. So I think that this will be it will be a good one. I'm also going to broadcast a lecture by Professor Michael Lawton on 22nd of December, and I hope that you will all be able to join it. I'm be sharing you the link to my WhatsApp group so that you can stay updated from all the future webinars. And the president of IFNI, the International Federation of Neuroendoscopy, will be joining us in January, on 29th of January. So I hope to see you all during his talk. And also, Professor Ted Schwartz will be joining us on 6th of January. He will be sharing his experience in tear-scalp-based neuroendoscopy procedures. You can join us on January 6th and January 29th. And also 1 week from now, on 22nd of December, I'll be so happy to see you at the lecture by Professor Michael Lawton. All of these webinars are recorded, and you can you can rewatch them as many times as you like on my YouTube channel. So please don't forget to, subscribe to my YouTube channel as well. I'll be sharing you, Professor, I guess. Professor Professor Shroeder, I can see you in the list. Hello, sir. Hello, sir. Hello, sir. Can you hear me? I think Professor Shroeder had some connectivity issue. He was here for a little time.
मैं रेकमेंड करती हूँ सेंसराइन रैपिड एक्शन का दोस्ताना बाकायदगी से इस्तेमाल क्योंकि ये फौरी असर करता है इट वर्क्स
Hi, Dr. John Bennett. How are you? Hi, Dr. John Bennett. How are you today?
Good. How you doing?
I'm doing great. How are you doing?
Well, I think you're doing what I like to do too, is to start early because you can network with people.
Yeah, I can. I'm trying to put your video on. I cannot see you. Oh
Okay, you
no.
need to you need to enable the video.
Yeah, exactly. That's what I'm trying to do. But I don't know what's wrong with it.
Yeah,
And
okay.
yeah. Uh,
You,
can you
you
send
may,
it? Can you
yeah,
turn it on? Can you turn
yeah,
it on?
you may have to go into your dashboard in your Zoom account to enable. Well, I don't know if you turned it off. Did you turn it off?
Oh, I don't know. I don't know. I will have to. Okay, give it a try, please. Give it a try. Can you turn it on?
Yeah, yeah. Okay, let me try it now.
Yes, please. Yeah,
Yeah,
I can.
okay.
Yeah,
There you go. There you go.
yeah. No, still, no. I couldn't see. Yeah, please. Yeah, hi. How are you doing today?
There you go.
How are you doing
Yeah,
today?
I really think before the conference is a good time for students to network. You know what I mean?
Yeah, I know. But I'm also, I'm very careful like you before the show because I don't want to miss any second or a minute so that everyone can be here and can join in.
Well,
It will be very easy. Yeah.
they have a good option now, Nor. They have a good option of translating into a language. You see
Yeah.
that?
Yeah,
That's
exactly.
fantastic.
It's
Well, you know
amazing.
why? I put it on anyway, so I can also see it. You know what I mean? In English.
Yeah. Oh, wonderful. You have, enabled the transcripts. I have also enabled transcripts and captions so that people can
Yeah,
actually
it's
read it.
enabled. I'm going to
Yeah.
save mine in English.
Yeah.
And that way, not only can I hear it, you know how sometimes it helps to see the text.
Yeah, exactly. And sometimes, many people are working in the hospital, so they have to mute the meeting. In that case, they can read the
Yeah,
transcript.
yeah.
Yes.
When I'm on the bus, I can
Yeah.
watch a webcast, read the subtitles, and watch it on the bus.
Yeah, exactly. And that's much more easier and much more, practical. So, I've
Yeah,
tried
yeah.
my very best to enable all those options that can help and assist people around the world because, I've
Well,
been through. Yeah,
Zoom will improve. It's a
exactly.
good company. It's a good company. They're going to
Yeah.
improve. They're going to continue to improve.
Yeah, exactly. And you once told me that they all the time listen to your queries and your suggestions. And I have experienced that they actually listen to one of my own queries and they try to implement it. And they have also, activated the artificial intelligence
Oh,
feature.
okay. So
Yeah.
you put a link to your WhatsApp so people can kind of talk there too, right?
Yeah, it's the WhatsApp group,
Good idea. That's a good idea.
Yeah, exactly. And also my website so that people can visit it as well. I have generated a quiz. I will share the link to that quiz at the end of the show, and everyone who submit the quiz will be able to receive their certificate immediately.
Hey, did you get any increase in your viewers and your registrants?
There were about 420 the last time I checked.
Oh, okay. Did I
Yeah.
help? Because I posted a lot today.
Yeah,
How?
I saw you. I saw you posting all the time over there. But I guess there we as long as we can see, there are plenty of people because we haven't yet started in even the meeting has
Yeah.
not yet
How many
started.
panelists do you have? You can't see the panelists. I can't see them.
No, no, no. I don't think
Oh, okay.
many
So
do
you don't
have.
have the
Yeah.
panelists then? Oh, okay.
Yeah, exactly.
Oh, you said you have people in the panel. You have about what? You have a lot. Wow, you have a lot. One, two, you have like
But
20
then
people in the
yeah,
panel, right?
yeah, exactly.
See if I can recognize any name. So this is a good time to network.
Thank you. And
Really? No, really. No, you can start your webcast like a half hour early and people can come in and meet people.
Yeah, exactly. And it also helps everyone to get admitted early so that they can join in and pick up from where from the very start. It's much easier. And many of the speakers they even wish to join early because they can do check their slides and everything. So it gets much better.
Okay, very good. Okay, Nora, I gotta head up and do some promote my own. I have a
The
big
mini
meeting.
congress. The mini
We're doing the
congress.
Spain. We're doing a big
Oh,
one in Spain tomorrow.
wonderful.
Uh, yeah, it's going to be a good conference. 2 days. Lawton speaking there. Well, some of the Japanese cerebral vascular surgeons are going to, you know. Okay, I'll
Lawson will
let
be
you get
joining.
ready.
Oh, one thing. Dr. Lawson will be joining us on 22nd. I have invited him on the 2nd of December, like that's next week.
Okay, say hello to him.
I'll share the flyer.
Okay, bye-bye.
Bye. See you.
Good luck.
Thank you very, very much. So, everyone, this is Dr. John Bennett from neurosurgical.tv, and you all know him very, very well. And we have a lot of wonderful, collaborations. So, he's also always around, and he will be airing all these programs on neurosurgical.tv as well. He will also be keeping all these programs on his website, so you can just go and see his library as well. I have also generated my own digital library. You can just visit this digital library anytime, and you can access all the videos that you wish to see. And again, thank you very much for joining in. You can use the chat box and share your messages, your comments, your suggestions, or any question during the lecture that you wish to ask to Professor Henry Shroeder. We will take up all the questions at the end of the session, and also all of these webinars are being certified. So at the end of the session, I will be sharing a link to a quiz. It's just a simple Google form. You will have to just submit it, and you don't have to worry about the grades, because the grades doesn't matter, and it is just for your own practice and for your own your own knowledge and learning and practice. So it's going to be just a formality, because I think that every learning activity needs to have a quiz, just for the attendees to have much confidence upon what they have learned. So after submission of the quiz, you will be able to receive your own certificate. The certificate will have your name on it, and it will be generated automatically. It will be emailed right to you. And please feel free to join the WhatsApp group. I've shared the link to the WhatsApp group, and you can join the WhatsApp group of the news network, and you will be able to stay updated about all those. Professor Shroeder is here. Hello, sir. Hello, sir. Thank you very, very, very much for joining us today. Hello,
Hi.
sir.
Hi, hello.
Hello, sir. Thank you so much for joining us today and for sparing time from your busy schedule. We are so honored and excited.
Just in time, right?
Yes, thank you very, very much, sir. I was wondering if the link is working and everything, the natural anxiety an organizer has. Again, sir, thank you very, very much. We are so much overwhelmed with joy and honor to see you here with us today, sir. Thank you so much.
My great pleasure.
Sir, I think that people are joining in. So if you like, you can start now, or if you would like to wait, then we can wait for about 4 minutes. If you say so, we will proceed accordingly.
Let's wait until 4 and I come back, okay?
Sure, sir. Thank you. This is Professor Henry Shroeder. I don't think that he needs any introduction, because all of us know him so well. And I'm myself a huge fan of Professor Henry Shroeder. When I started my residency so many years ago, I came to know about him, all this neuroendoscopy. I think this was what created a lot of interest among us, the young neurosurgeons, in neuroendoscopy. So Professor Henry Shroeder is the professor and the director of neurosurgery at the Greifswald University in Germany. He has, his contributions are so numerous, so, tremendous, that every one of us can very well know about him. And he's also been in several leadership roles in neuroendoscopy, neurosurgery, and he's just completed his term as the president of IFNI, the International Federation of Neuroendoscopy. So it's like he's usually so busy, and I was quite when I sent him a message, I knew he's such a busy person, and we would be very lucky if he could actually spare a moment to deliver a lecture. So today he's there, and I'm so happy that you are all here, and we can all learn together. Yes, sir. Thank you very, very much, sir. Again, thank you so much for joining us today, sir. You can check your slides if you like to.
Yes, just one question. So you
Yes.
are all students, or you are young residents, or what is the audience?
Sir, I have completed my training, so I'm a neurosurgeon, and most of our audiences are either junior consultant neurosurgeons or trainees, and we have only a few medical students, not much.
Okay. Good.
So thank you so much, sir. Sir, I'm a huge fan of yours, and I remember I actually joined your course on fellowship on neuroendoscopy, the Gapswell course for Cairo, but I wasn't able to complete it because I was not an Egyptian. I just completed module 1. So but it was a wonderful experience. I learned a lot from all your wonderful videos, your lectures, everything.
Yeah, you can try again. Maybe next time you will be able to come.
Thank you so much, sir. I will be doing that. I actually emailed them and asked them if they can if I can do it. I'm not an Egyptian, but if I can, I wanted to request them if I can have this privilege. So again, thank you so much, sir. I cannot find the right word. I'm so excited to welcome you here and see you here, especially from your very incredibly busy schedule. And I've been seeing your lectures, your IFNI conference and everything, sir, again. So thank you very much, sir. If you like, should we start the webinar officially now? If you
Yes,
say,
you should start now.
thank you so much, sir. Thank you so much, sir. So everyone, it's a pleasure and honor to see you here, and it's a matter of huge excitement and honor for me to welcome the esteemed Professor Henry Shroeder to our neuroendoscopy webinar series today. Professor Henry Shroeder is the director and the professor of neurosurgery at the Greifswald University in Germany. And Professor Shroeder doesn't need any formal introduction, but for a sake of formality, I wish to tell you that he has pioneered several of the techniques that we know about today. He has written so many research papers and chapters in several of our books, and Professor Shroeder has been president of IFNI, the International Federation of Neuroendoscopy. He has been very active in neurosurgical education, not only in excelling surgery. He's been so dedicated, and we all owe him a lot for his dedication towards neurosurgical education. That means so much, especially to neurosurgeons of my age group who are learning and having luck in learning more about neuroendoscopy. So it's so lucky for us to have him today. He will be delivering his wonderful lecture on endoscope-assisted skull-based surgery in the posterior fossa. Professor Shroeder, thank you very much for joining us today. The floor is all yours.
Thank you, Noor, for the very kind introduction. I am not the president anymore because in Singapore we had the 10th World Congress and I gave it over to Alvaro Cordoba from Uruguay. So we changed, of course. So the next World Congress will be in Graz, so you are all invited to come in 2 years. So my topic is endoscope-assisted skull base, and I said I want to focus on posterior fossa because that is an area where you can use the endoscope very nicely. Can you see my slides moving?
Yes, sir, we can.
That's good.
Thank you.
So first about anatomy, you have to know the anatomy very well in the normal condition, because when you see the morbid anatomy, then everything is distorted. So you have to know where are the nerves normally running to expect where could they be when the tumor is growing from this direction or this direction. So you have to learn, of course, first the anatomy, and you can do it with anatomy books, or you can take the Roton Atlas, which is very nice. And you can also go to Cadaver Lab, of course. So here's some nerves. Then what also is for us very important is the internal aortic canal, because we have some lesions which are in the canal. We have some lesions which are irritating the nerves. We have the jugular foramen, hypoglossal canal. So this is a view what you get with with a microscope when you make a retrosigmoid approach. And this was an epidermoid. And you see here, trigeminal nerve, 7, 8, and the lower cranial nerve group is here. So with a 30-degree endoscope, the overview is limited, but in the same patient, you can use an endoscope and you see much better. I will show the video later. So this is the lower cranial nerve group. First is glossopharyngeal. It's always separated when it goes to the foramen with a fibrous band. So it's not going together. It's the same bony opening, like the vagus nerve is running through, but it is divided from the vagus nerve by a fibrous band. Then what people frequently not know is these fibers. Many people say, oh, this is a vagus nerve, but it's not. Does anybody know of you which nerves are this here? You see, this is 9, 10, and this is spinal accessory. What is this? Very small nerves, but very important. Anybody has an idea? No? So this is a radixis cranialis, so the cranial branches of the accessory nerve. And these are containing the fibers for the larynx. So when you cut such a small nerve, it can result in permanent hoarseness because it joins the vagus nerve and then it runs with the recurrence nerve to the larynx. So very important, very small nerve fibers, but very important. And sometimes you have to dissect in between, and because they are so small and vulnerable, it can happen that you have temporary hoarseness. But as long as the nerve is intact, not ruptured, it's okay. This is a view to the trigeminal nerve. You see here's trigeminal nerve running. This is Meckel's cave. Here's the brainstem. You see here's the loop of the SCA, what we frequently see in trigeminal neuralgia. And this, of course, the sixth nerve, abducens nerve. So now I show you the video how this area looks with an endoscope. This is a 30-degree endoscope used during resection of an epidermoid in the CP angle. You see, this is the internal arterial canal. You see here is a small remnant. 7 and 8. You see 9. You see the fibrous band between 9 and 10. So glossopharyngeal, vagus nerve. Then the big one here is the spinal accessory, and here's the small branches are the cranial branches of the accessory nerve for the larynx. And you see this is a jugular tubercle, and you cannot see where's the hypoglossal canal. With a microscope you don't see, but with an endoscope you can look behind the tubercle and you see here a hypoglossal canal. So it gives you much better overview when there are tumor remnants or when there is a small meningioma going down. You can see it with the endoscope without the need to drill the tubercle. Then we go up again. This was internal canal. This is the vagus, the abducens nerve going to Dorellus canal. This is 5. This is Meckel's cave. You see frequently we have tumor of the epidermoids in the Meckel's cave. And then we can go under the tent. And which nerve we see here? Of course, fourth nerve. Trochlear nerve, the only one who comes from the posterior part of the brainstem. Some remnants here, which can be removed under endoscopic visualization. And then you hear the last nerve, what we can see is the oculomotor nerve. So the epidermoids, they push everything aside. So you have a very nice overview over the anatomy. And you can find tumor remnants which are not seen with a microscope. So one approach which we usually use in most of the cases for posterior fossa lesion is simple retrosigmoid approach. So we are not fan of the extended posterior petrosal or anterior petrosal. We do that all very rarely. In most of the cases, we can deal with it with the use of the endoscope because the additional angle of view you get with these extensive skull-based approaches can be seen with a simple retrosigmoid approach when you use endoscopes with different angles of view. So we have 3 parts or 3 kinds of retrosigmoid approach. We don't make the whole thing. We usually make small tailored approaches depending where we want to go. So superior, middle, and inferior. So the superior is just in the angle between transverse sinus and sigmoid sinus, small craniotomy, about 2 centimeters in size. For example, for trigeminal neuralgia. You see, this is a microscopic view. With an endoscope, you see this much better. Then the middle retrosigmoid approach is just behind the sigmoid sinus. That is used for vestibular schwannomas, CP angle meningiomas, epidermoids. You see this is internal arterial canal. There's some tumor. And you see here's the vestibular nerves in the back. And the inferior retrosigmoid approach is far down behind this sigmoid sinus. This is the approach to the lower cranial nerve group, to the tuberculum celli. We use it for hemifacial spasm most frequently, but also for tumors in that region. So the concept of endoscope-assisted microsurgery is that we use for most of the surgery the microscope. But if you have small openings, you see you lose a lot of light of the microscope, and inside the illumination is poor. And you cannot look around the corner. With an endoscope, you can bring the eye close to the lesion and have a much better view. So when you look for the microscope, the advantage is we have 3D visualization. We have a high resolution because the lens is 12 millimeter in diameter or 14, depending on the microscope. But what is the disadvantage? You have a very narrow field of view. You don't see what is on the side. You have a poor illumination in long, small surgical corridors, and you have a poor depth of field. And with an endoscope, you go in, perfect illumination, wide angular view, very good orientation, and you can use angulated scope to look around the corner. And then you see much better. So the advantage is magnification, large depth of field, wide angular view, and you can look around the corner. The cons is you have usually 2D visualization. There are some 3D endoscopes, but many people I know, they switch back to 2D, because this 3D visualization is a little bit overestimation of depth. It's not the natural depth you see under the microscope. So that's why I have used some 3D scopes to test it, but when you are used to the 2D visualization under the endoscope and you have used it for years, you feel not comfortable because everything looks different in the depth perception. When you start with 3D endoscopy from the beginning, I think you get used to it, and all the gamer generation will use it, I think, more frequently than the old generation of surgeon use. But all our surgeons, also general surgeons, they have a very nice 3D endoscope, but they use it only for the course. When you see them during clinical routine, when I go into their OR, usually they have 2D endoscopes. But even if you use 2D endoscopes, because of the fisheye effect, that means the distortion of the image and the motion parallax. Motion parallax means that closer objects move more than distant ones. You get a pseudo 3D impression, even if you use only a 2D endoscope. So you have some feeling for the depth after a while. So for endoscope-assisted surgery in a CP angle, we use small endoscopes, 2.7 millimeter in diameter, different angles of view. And of course, you need angulated instruments to get tumor, which you can only see under an endoscope with angulated view, of course. So I'm still the fan of the old Image One HD camera. There are 4K cameras available. They have a better resolution, but the color fidelity of all the models what I have seen are not better. And when you use just a 26-inch screen for surgery, what we have in our OR, you don't see the difference in resolution when you compare HD and 4K. So I'm still a fan of HD camera. And you see when you go very close with an endoscope to the vessels, so this is in contact mode with an HD camera, you see even erythrocytes running through the vessels. So these cameras together with an rod lens endoscope gives the best optical quality you can get. All chip on the tip endoscopes have not the same resolution. So it's not a contrary, but microscope and endoscopy should be used together, in my opinion. That is the best, because both of these optical visualization tools have advantages and disadvantages. You see, when you use a microscope, what is the advantage? You see the shaft of your instrument. So when you work in between 7th and 5th nerve, then you can go dissect in the depths, but you see when you touch it. In the depths, the resolution is not very good. That is true. But when you touch the structures, you see it. Endoscope is different. Now you come in, you have the nerves here, it's okay, you have control, but if the lens of the endoscope has passed the structure, you see very perfectly in the depths, but you don't know what your instruments are doing to the nerves because you don't see it. That is, of course, a disadvantage. You see, when you go in, you see this epidermoid, this is a clivus. On the contralateral side of the clivus, there is a tumor remnant. And when I try to dissect with a microscope, it's hard to see, but I see when I move the nerve, so I know, aha, doesn't take care. Now I have the endoscope in, I don't see what I'm doing with my instruments to the nerves, which are not in the visual field. That's a little bit a disadvantage of the endoscope. And the other thing, what you have to take into consideration is the heat generation. Although it's called cold light fountain, the light for the endoscope, it becomes very hot. It can even burn a hole in your draping. So when you put the endoscope in front of a nerve, you have to always irrigate to keep it moist. Otherwise, it will become dry and you can make a thermal damage. Very important. The question is, some people advocate pure endoscopic surgery, and they state that you have a wide angle of view, good illumination, and they make very superficial tumors under endoscopic view. In my opinion, that makes no sense because the microscope gives you 3D view, better ergonomics, better visualization. So I don't understand this, to be honest, because this is not an advantage. The endoscope is designed to look into something in a narrow corridor, deep corridor, look around the corner. So I don't think that is an advantage for the surgeon as well as for the patient when you use an endoscope for all surgeries. You see here we dissect an epidermoid, which is close to the lower cranial nerves. There is this perforator which is attached to it. So we have to dissect this perforator away to avoid a brainstem ischemia. And you see this can be nicely done under microscope. What is the advantage when I use an endoscope for this step? It's very superficial. I have a perfect view. I have a three-dimensional view. And this, in my opinion, would not make sense to use in this case an endoscope. Different is this. There is, on the other side, tumor going into the internal arterial canal, and the tumor is hidden behind 7 and 8. So I can use now a 45-degree endoscope, and I can remove the tumor from the internal arterial canal without the need to open it, to dissect 7 and 8, because I can look around the corner and I can remove the epidermoid in this area. For then, of course, it makes sense. 3D endoscopes, I told you already, I have tested it. It is nice for viewers. When you look at the screen, it's like in a cinema, you have a 3D movie. But in the end, I don't see it's a big advantage. We have also used exoscopes. That is, you don't look through the lens system anymore. You just look to the screen with the 3D glasses. But also, in my opinion, nowadays, it's not ready to replace the microscope because the guidance is not as good as I want to have it. I always use a mouthpiece. So when I go in and out, left, right, I never bring my instruments away. I don't have to refocus. I go with a mouthpiece, with a microscope, left, right, in, out. So that's why it's very, very ergonomic. With the exoscope, you have to give your hand away. You position it with a joystick, or you position it with a hand. You correct the positioning always with a hand. There's no mouthpiece. Of course, there are some robotic systems where they have a foot pedal. And when you are very familiar with the foot pedal, maybe you can also guide the exoscope the same way in an ergonomic manner. But many systems are just manual repositioning. That is not good, or you have only a joystick. That, in my opinion, this disturbs my surgical workflow. I want to have my mouthpiece. I go in, out, and I'm very efficient with this. But this is a matter of training, of course. And I think in the future, the exoscopes will replace the microscope. I'm pretty sure, but it will take more improvement of the technology. So surgical technique of endoscope assisted means we start with a microscope. We make microsurgical resection. Then I use the endoscope freehand for inspection. And sometimes I fix the endoscope with a mechanical holding arm to have the ability to do bimanual dissection. That is especially important in tumor surgery. Here the screen should be in front of you for economic reasons. Some examples. Vestibular schwannoma. Should we operate on every vestibular schwannoma? This was a young guy. He came in 2010. He is a sports teacher, and he asked me, what should we do? I think you are a young guy. Tumor will grow. So I would recommend that we make the surgery and remove it because it's the best chance to give you hearing preservation. The hearing is still good, tumor is small, it's not reaching to the fundus. And then he asked me, I'm a sport teacher. I have to make these exercises on the high bar. So I go up and make a salto and come back. I said, this I cannot promise because it may happen that you have some balance problems after a while, after the surgery. And then he said, no, so then I don't want to do it. And he now just came yesterday in my OPD, and this tumor, you see, is a little bit larger, but he has still functional hearing, and that is now 13 years later. So you never know exactly. So one option is before you advise for surgery, you make an MRI after 6 months and see the tumor growing. Usually it's not growing after 6 months. And you say, okay, I do it after 1 year. And when you see growth, of course, we recommend surgery. But if there is stable tumor, stable hearing, the option is also to wait and scan. You see, it's still good hearing over the time. But of course, most of the tumor grow. This is a lady, she has hearing problems, but has still good hearing. The tumor goes almost to the fundus. So what should we do with this? Surgery. We make a retrosigmoid approach. You see, we place the patient supine, we turn the head 45 degrees, a little bit shaving, then we make this curved incision so that we are able to look with a microscope to the fundus. And of course, we have monitoring. And then you see we tilt the whole table another 30 degrees, and then the cerebellum falls back by gravity alone. Monitoring of facial nerve and of course of the cochlear nerve for hearing preservation. Middle retrosigmoid approach, small craniotomy. It's very important that you see the margin. The biggest mistake what I have seen in retrosigmoid approach is that people have some bleeding from the hemispherical vein and then they stop. And then the bone goes like to this area. You see, then you cannot look really down. You have to compensate with cerebellar retraction. That's very bad. So you should always expose the margin of the sinus, and then you make an incision parallel to the sinus, place 3 tucking up sutures, and then you can look down on the skull base without the need of retraction. That's very important. What I use, like suction spatula, there is some holes, and you can connect a suction tube, and then you place it in the lower area of your surgical field, and then it takes all the CSF away. So my assistant is always irrigating, and the bloody CSF is aspirated, so I have a very good view. You see, we place it here below the nerve, below the tumor. That's very nice because it gives me a third hand. So I don't need any suction. You see, it's a vestibular schwannoma. I like to have a forceps to keep the tumor. And then I have a second forceps where I dissect the nerve from the tumor surface. And I have always irrigation. So even if there's some blood, I have a clear view. That's the advantage of this suction spatula. So this was the one guy. He came with hearing loss on the right ear. And an MRI shows the tumor on the left. So what to do? Of course, he was advocated to get gamma knife. But when you look at the literature, gamma knife has also not the best hearing preservation rate. After 10 years or 15 years, many patients lose the hearing. And you see left side is very good, the hearing, right side is very bad. And this was a study from Vienna. And you see they had a very good local control rate after radiation, but hearing preservation at 15 years was just in 1/3 of the patients. And even one malignant transformation was seen. So that's why I think it's always also an option that we make surgery. But if the tumor is in the fundus, we have to drill the posterior wall of the internal auditory canal without opening of the vestibule on the posterior semicircular canal. And then we have still a blind corner because when we make a small opening like here, we cannot see to the fundus. So we need some endoscope to look around the corner. See here, the internal auditory canal is opened. We dissect the tumors, the vestibular nerves on the left, the posterior, the superior and inferior vestibular nerves. The medial part of the tumor is resected, as you can see now with the view under the microscope. But here, the lateral part in the fundus, I cannot see well. So I switch now to a 30-degree endoscope. And under direct visualization, I can dissect the tumor from the lateral aspect of the internal auditory canal. I can look until I see the fundus. And that's a big advantage. So as you see, I don't need to touch the nerves. I just go to the tumor, which is clearly seen. With the microscope, it's blind. You can take a hook, but you don't see. And you see is a transverse crest. And here was a vestibular schwannoma. And here are the fibers, residual fibers of the vestibular nerve. And below is the facial nerve. So in my opinion, this is a nice indication to use endoscope assistance. You see, I could drill 1 millimeter more, but if I go too far, I open the vestibule. And he preserved his hearing in a good fashion. And it's now, I think now it's 8 years or so, or even more after surgery, and he has no recurrence so far. What is the strategy in large schwannomas? In large schwannomas, initially we put them also in a supine position, but you see all the fluid is inside. I need to have a suction and dissect the structures from the surface. I cannot use very nice both forceps with traction, counter traction, what I like. So that's why I changed now to the semi-sitting position. Semi-sitting position means when I irrigate, CSF runs out and have a very good view. Of course, we need endoesophageal echo to detect air embolism. That is very important because this can happen, and this might be a risky thing if it happens. So incision is a little bit larger because CSF should be drained by gravity. And another disadvantage of this approach is that you always have to retract the cerebellum up a little bit to get access to the tumor. But it's not much, and it's not a big problem. So the disadvantages of the semi-sitting position is not semi, it's a semi-sitting position, should really be written. Risk of air embolism, pneumocephalus, and cerebellar retraction. But the advantage is that you have a very, very nice view. So this is a young girl with a huge vestibular schwannoma on the right side. Hearing was still good, surprisingly. And this is the position what we do. You see the feet is up almost at the level of the heart so that you have enough venous blood in the body. Then you see this incision a little bit larger than in the supine position. We have to open downwards that the CSF can fall down, comes out, drain out. So the first step is now opening of the internal auditory canal with a high-speed drill. Initially, I take the cutting drill and then the last piece with a diamond, and I'm looking for the nerve as a stimulator. Then coagulation of the tumor capsule and vigorous debulking with ultrasonic aspiration after we take a biopsy. So this helps a lot when you make a decompression. You see now, this is a nice plane. You see the shiny tumor surface? Shiny tumor surface, you see all these are nerve fibers, residual vestibular fibers, and then later on we see facial nerve. You see in the upper part of the internal canal, facial nerve, verification with stimulation. This is tumor tissue. It's resected. And you see again, this is a tumor, the grayish, and the white things are the nerve fibers. This is a cochlear nerve here. So we come from below and dissect from below above. This is all tumor capsule. And you see nicely how you can dissect the nerves away. Ultrasonic aspiration. And again, you see here, very nice plane. This is the upper pole of the tumor where the facial nerve is coming. See, this is the facial nerve running here. But you see there's a nice plane where you go around. This is a facial nerve running here. Very thin fibers. Above is a trigeminal, the white, but this is a facial nerve. Here, facial nerve, and you see it's a nice plane where you can dissect. And all is done under continuous irrigation. So the tumor is dissected completely. And then finally, we can take it out. You see this is a resection, no obvious residual, and good facial function, even in the post-op period and the post-op MRI. The question is, in this large tumor, should you always make a gross total resection? This was a surgery I did many years ago, and it was, of course, always the aim to make gross total resection. But the fibers of the facial nerve can be very sticky, and then, of course, you have a problem. So she's 10 years out of surgery, but you see, this is not nice. It is not symmetric. If she smiles, it's also not. People say it's a grade 3. House and Brackmann, it's a good cosmetic result, but I don't agree. I think it's not a good result. good result is when you have a normal face. So this lady came to us, 70-year-old, huge tumor, and the local neurosurgeon said, no, we will definitely have facial palsy. We cannot change this. It's your destiny. Then she came to us and I said, yeah, we can try, of course, to preserve, but maybe we have to leave a small capsule on the nerve. So when we go in, this is a tumor. So again, we open the internal auric canal. All is done under the microscopic view. And then we dissect the tumor. You see the facial nerve comes. It's the internal auditory canal. Ultrasonic aspiration. And you see again, we are looking for the nerves. Good plane. Here's a cochlear nerve. Dissect it away. Always irrigation. This gives you a very nice plane. That is very important that you find the right plane to dissect. There are always some residual vertebral fibers, which can be as a protection for the facial nerve. And then in this case, we had to leave a small layer of tumor capsule along the nerve. Now here is the facial nerve, and we leave a little small. You see, with an endoscope, we can look, are there open air cells, which are hard to see under the microscope, and then we plug it with muscle. So in this case, we left a little bit of the capsule. And you see, here is a little bit of the capsule. The nerve is always most adherent when it comes to the entrance of the internal auric canal. And in this case, sometimes better you leave it. When you hear in the monitoring the pathological trains, then it's a high risk that the facial nerve will not work well. But we want to see this, and we want to have a lucky girl. I think this is most important. It's now over 10 years, and the residue is not growing. So far, she did not receive any radiation. Another case, 36-year-old male, also same thing, large tumor. We left a little bit of the capsule, good functional outcome. He's now more than 10 years out of surgery. You see, you don't even see where is the residue. So small, just a small piece of the capsule attached to the nerve. Another lady here, 30 years old, came from Kuwait. You see a huge tumor. And these cystic ones are especially ugly because they are very sticky to the surroundings. Very, very sticky. So we made the same. You see, we had to leave tumor along the course of the facial nerve, but she has a good facial outcome. So we have always to take the function in mind. This is the most important thing. And you see, we have post-op some pauses, but if it's just grade 3, it recovers very well. If you have grade 6, it means the total palsy, it will never come back completely normal. And that should not be our aim. So, one moment, ein Moment. Hallo, ich mache gerade ein Webinar. Ich komme morgen. Ich zeige dir es morgen, okay? Sicher? Oh, sorry. So sometimes the facial nerve cannot be preserved. This is a lady. She had an NF2. She is deaf on the left ear, and this tumor is progressing. This on the right side, she has still good hearing and is not progressing. So the indication was for the left side, and she presented already with a facial palsy. Sorry, ich muss ganz kurz. Ja, Micha? Ja, ich weiß, du hast bis jetzt Tumorboard gemacht. Lass uns das morgen früh angucken. Ich habe jetzt ein Webinar. Okay? Und wäre schön, wenn wir vielleicht nochmal einen MRT-Termin kriegen können für eine Schulter. Die ist wirklich, ist irgendwas noch fast passiert. Ich kann jetzt nicht mal nach unten mehr fassen. Und Dirkie ganz meint, wir sollen nochmal machen. Aber es irgendwie geht morgen irgendwann. Oder Montag, geht auch. Alles klar. Schönen Feierabend. Ciao. Sorry, this was our neuroradiologist. So you see, this lady has already facial palsy, and you see it's a very severe facial palsy. So in this case, you know, when you make the surgery, it will be difficult to preserve. You see, this is the facial nerve running here. This is all the tumor. Initially, I tried to preserve the facial nerve, but the stimulation here does not give really a response. So we open the canal. This is in the supine position. So I open the canal. Then tumor is resected. As I said, I tried to preserve the nerve, but the nerve was completely gone. There was no plane to dissect, you see here. And then I just cut the nerve close to the brainstem, where the nerve is really still a good nerve, where we can expect some regeneration. And then I dissect the tumor from the surrounding structures. And our ENT colleague, he made a transmastoid exposure of the distal facial nerve in the mastoid area. So you see, this is facial nerve. I cut it. So vestibular, this was the vestibular part of the tumor. And then I make a communication to the field of our ENT. And you see here is the area from the ENT. So we took a sural nerve graft. Six centimeters. And here I cut the facial nerve in the mastoid. See, this is a distal stump. And then we place the graft. Here is the brainstem stump of the facial nerve, and this is a distal one. You see, it fits very well to the nerve. I put some fat in the opening when we connect, and I just did not stitches, I just glue, because the nerve, especially at the brainstem, has no epineurium to suture. We just put fibrin glue. This is the approach from the ENT. This is my approach, and here we made the connection. 3 months after surgery, no 1 year, no recurrence. This is 1 year after surgery. And you see, in rest, she has the symmetry. So it's much better than before the surgery, where she could not close the eye. So I think it's a very nice surgical result after facial nerve reconstruction. So another good indication for endoscopy assistance is an epidermoid. So this was a lady, she had 2 surgeries for the epidermoid and lost hearing after the first surgery. And you see in the MRI, she has still a tumor indentating here cerebellar peduncle and the midbrain. When you look to the coronal view, you see the tumor goes far down here. When you come with a microscope, you look just in this direction if you make an interventorial approach. But when we did this, we removed this part and then we look down 45 degrees to resect this tumor. So a superior retrosigmoid approach is done. So when we start here, the first thing what I want to know in this case is, of course, where is the trochlear nerve? Because this is the tent, the edge of the tent. So with a microscope, I can't see where is the trochlear nerve. So I look with a 30-degree endoscope, where is my trochlear nerve? And then you see it comes here from the tent, and the tumor pushes the trochlear nerve away from the tent to the brain stem. So with this knowledge in mind, of course, I know I can be very aggressive at the tent edge because the tumor is, the nerve is not there. So that's why I could make a very rapid and aggressive resection of the capsule from the edge of the tent because the tumor, as the nerve is not in this area. So, and then in the back, after resection of the tumor, I was looking for the nerve, and you see here down, there is a trochlear nerve coming, and I just follow it anteriorly. And although it was a recurrent case, in this case, I could remove all of the tumor, including the capsule. That is not always possible, especially in epidermoid recurrences. Usually the capsule is very sticky, but here I was lucky. You see, I have a very nice plane, and I can remove the whole capsule from the brain stem. And now I use a 45-degree endoscope looking down to the tumor part, which is down in the cerebellar peduncle. So the tumor is resected under view of a 45-degree endoscope. You see I have a curved dissector, curved suction. And so I was able to remove all the tumor, even this which was far down in the peduncle. And this is a result. I don't know, I think it's also over 8 years or so. You see, we could get all this out, and she is doing fine so far. Another case, facial numbness. You see a huge tumor with dilation of Meckel's cave. You see this Meckel's cave on the normal side, and this elongation, enlargement of the Meckel's cave. It's a sign that must be a benign, slowly growing lesion. When you look here, you see it is not almost, well, it's not completely, but almost iso-incident to CSF in both. So usually this is an epidermoid, but here is more hyperintensity, so more fat inside. So this was probably a dermoid. And then we discuss this case. What is the best approach? Some people say, oh, we make anonasal. Some people say we make subtemporal. Some people say we make combined subtemporal retrosig. But we said we make it simple. We make just the retrosig. We remove the thing which is compressing the brainstem. That is a major problem for her. And then we take a 45-degree endoscope to look to Meckel's cave. So we have here the tent. This is the petrous bone. We open the arachnoid. See, this is all dermoid. You see some hair. Sometimes you find some teeth. Here was just hair and fat. This is 7 and 8. So we try to find a good plane. Traction, counter traction to dissect the membrane from 7 and 8. Then up we see trochlear nerve running here. And these are the fibers of the trigeminal nerve. You see, massively flattened, thin, because the tumor put a lot of pressure. And then we follow the nerve into Meckel's cave. You see it's a blind curettage. We don't see very well. That's why I changed to 45-degree endoscope, and we can look inside, and it's not a blind curettage anymore. You can look in 45-degree. You see it's all tumor. And then with different curettes and curved suction, we make a complete evacuation. But no attempt was made to dissect here the fibers from the capsule because they were so adherent. You will destroy definitely the fibers, and then she has no sensation in the face. So that is not a good idea because the capsule was too sticky here. But we have a very good evacuation. You see, of course, the tumor will come back after a while, but this can last many, many years. And then after 10 or 12 years, you can make a second debulking if required. So this was a lady with progressive gait and balance problems. MRI showed foramen magnum meningioma. What is the best approach? Some people say, oh, anonasal is good, but then you have to resect the atlas, anterior arch, and also the odontoid, and then you have instability, so it makes no sense in my opinion. The tumor goes more to the left and goes with the other extension to the right side. So the best would be to make a far lateral from the left. But I never resect the condyle. I just stop. And then what you see is here. This is a spinal cord. This is the spinal accessory. Here a lot of fibers. So this must be C2. A lot of sensory fibers. So we dissect the tumor under microscopic view, ultrasonic aspiration, debulking, and then we dissect as much of the tumor as we can get. Bring it out. But now you see there is a blind corner at the anterior aspect of the clivus. This is not be seen without drilling of the condyle. So I use now a 30-degree endoscope. Then I can look directly to the dura anteriorly. You see, I take the inner layer of the dura. I just leave the periostal layer behind. So I have a very good resection of the tumor, and then the periostal layer is just coagulated with bipolar. This is just possible because I have a 30-degree endoscope. If I don't use an endoscope, I cannot see this area. And I have a bind area. You see, this is a microscopic view. I see very nicely here, but the anterior part I cannot see. Then I would need to drill more, but can avoid it when I use the endoscope. You see the post-op CT scan shows the amount of drilling just behind the condyle. We stopped. And MRI, no recurrence so far. Another example, jugular tubercle meningioma. Goes down here also. This is also difficult to see. It's a microscope. So we come here in, dissect the tumor, then we use an endoscope for coagulation and dissection and removing of tumor at the hypoglossal canal because I can look down in this area. So another case is this. This was a 18-year-old female, sensory loss of the tongue, dizziness, ataxia, a double vision, hemiparesis, facial palsy. So many problems. You see there is a cavernoma which bled outside of the lesion. So extralesional bleeding into the brain stem. What is the best approach for this lesion? So many people say, yes, we make subtemporal. But you see, when you come from the side, because the tumor goes more to the left, and that's the brainstem, you have here the big vein. So when you come in here, the vein is maybe attached to the dura. Then you have to dissect it from the brain, or you detach it here, but it will be difficult, and it's a risk that you damage this vein. And subtemporal also has a problem when you resect the lobe, that you have some signal changes. So that's why I thought maybe we just make an endoscope-assisted retrosigmoid approach. So we did a retrosigmoid approach. You see the bulging of the pontine area, the 7 and 8, here's 5. So we open here the cerebellomedullary fissure and went to the middle peduncle. So we expose the middle peduncle, and then with navigation, we dissect to the cavernoma. It's a long way, but it's through the cerebellar peduncle. And that is a very forgiving structure. So we are in now, and we resect step by step the cavernoma. This is all done under the microscope, because when I place here the endoscope, I cannot move anymore, because the opening in the brainstem is just 5 millimeters. So we dissect around, and then you have to be careful, because frequently there is a DVA associated with the brainstem cavernoma. Here we use the endoscope just to inspect where we see some remnants of the cavernoma. And you see now it's relaxed. Brainstem is relaxed. And post-op, so resection of the tumor, you see this is the approach. At 7 days after surgery, she improved markedly already. And some years ago, I met her at the petrol station when she was driving to a skiing vacation. So obviously balance and so is not too bad. So this was a very nice approach. This is also an interesting case. This was a 20-year-old male, sudden ear pain, tinnitus, hearing loss, and facial palsy. And he came with this lesion. We were thinking, what is this? The enhancement is not typical for a vestibular schwannoma. The dilation of the canal, yes, should be something chronic, slowly growing, but was very difficult. And I have never seen a vestibular schwannoma which is causing facial palsy, never. So what we said, we have to look what it is. We have to do something. There's a problem for the guy. So we open it. You see, this is 7 and 8. You see Ica loop going into the canal, what we frequently see. Then we open the canal. We cut the dura. And then we go in between the vestibular nerves, and we see a bluish structure, very strange. Seems to arise from Ica. Then we cut the vestibular nerve because it was anyhow not working. And what we see, what is it? This is a thrombosed Ica aneurysm, an intrameatal Ica aneurysm. This is thrombosed, but here was some flow was visible before the surgery. So what we did, we opened the aneurysm, and then we make it in arteries, endarterectomy, and we take the thrombus out. So you see there's back bleeding, or there's bleeding from the proximal part. I put a clip. Then we open the distal part, which goes into the distal Ica. We remove the clot, and you see there's a little bit back bleeding. So that is a question what we do now with the aneurysm. Clipping is not possible, rod-based. So we excise the aneurysm, and then we make an end-to-end reconstruction of the Ica. Question is it really necessary, or we had just to resect it and coagulate it because we had a good back bleeding and the pica was the main vessel. but you never know what's happening. So that's why I thought it's worthwhile to reconstruct. So we make interrupted single sutures. First, you suture the anterior wall, then we can switch, turn the clips, and then we have access to the posterior wall. Very important that you make sure that you do not grasp the anterior part when you suture the back wall. That is important. So then we open the distal clip first. It's a little bit of bleeding, but it usually stops after a while. Sometimes you need a second suture at some point, but here, after a while, it stops, and you see the good flow in the Doppler, and then we performed an ICG angiography, and you see it's a good flow. And this is a post-op angio showing here the anastomosis side with good flow. So he improved in facial palsy, but hearing, of course, did not improve. For annual clipping, we use the endoscope also, but not so frequent. This was an interesting case of a female with unsteady gait dizziness. It was interesting. She had edema in the brainstem, and the reason was that the pica aneurysm was always hammering to the brainstem. So coiling was initially the idea, but you see it's a broad-based aneurysm, and our radiologists say when we put coils here, it's a high risk that the pica is occluded, and this is a major vessel. Ica is very small, so that's why they said, no, it's not possible, and she came to us, and then we made an inferior retrosigmoid approach. But when you come from here, you see only the cranial nerves are in front of you, you have not wide access. So we use a 45-degree endoscope, go in, we see here the vertebral artery coming, this is a pica, and this is the aneurysm, broad-based aneurysm, and in the back you see perforators. So then I tried to clip the aneurysm under endoscopic view, but when the endoscope was in, there was no space for the clip applier. So that's why I had to go back to the microscope, and then I mobilized the aneurysm out of the brainstem, dissect the neck. It was very stiff, this vessel. And then with my knowledge from the endoscopic visualization in mind, I put a clip and I closed the aneurysm. And then I was not sure, is the tip of the aneurysm clip really getting the aneurysm, or is there a problem? You cannot see it under the microscope. That's why, again, the 45-degree endoscope comes in, and you see the tip of the clip is okay, and the perforator is not in the clip. So that gives you confidence that after surgery, everything should be good. And this is after clipping. But in aneurysms, we don't use it much. For muscular decompression, we use the endoscope frequently. Trigeminal neuralgia, for example, is a very good indication. Superior approach, we make just a small incision and dividing the rectangular angle of sigmoid sinus and transverse sinus in the middle, small craniotomy. And then you see sometimes you have a very prominent suprameatal tubercle and you cannot see the course of the nerve to make its cave. And that's why it's very important. So here, case trigeminal nerve 7 and 8, you see SCA, and there's a prominent tubercle. You might think this is an offending vessel, but when you see 45-degree, no, it's a vein. And then on an endoscopic visualization, we just cut this vein and don't need to drill. What we make in the most of the cases, we make a transposition. See, this is the upper craniotomy. Endoscopic visualization shows a huge loop of the SCA compressing the trigeminal nerve. That's the classic finding, what you should find. And we dissect the arachnoid, and we open the arachnoid far along the tent to make really a transposition. So I don't like in trigeminal neuralgia to make an interposition. So most of the time I mobilize the vessel away, then I make a Teflon sling. And then we can put stitches, or what we also do sometimes, you take an aneurysm clip and fix it. But very important is that you have the vessel completely away from the nerve. So I don't like it that I put just Teflon between, because the Teflon itself sometimes irritates the trigeminal nerve. You see now it's fixed to the tent. It cannot slip away. And then you see with an endoscope, which was very nicely, there is no contact of anything to the nerve. So this is the best decompression you can achieve. This was a case with a megadolicho basilar artery, trigeminal neuralgia. Now you see this is the trigeminal, the 7 and 8, and this is abducens, massively elongated from this big basilar artery. So what can we do? What should you do? The thing in here, the idea was that the problem is really on the brainstem side. So that's why I mobilize. You see there is the ICA loop coming here from the basilar. So I put some Teflon between ICA and basilar and the brainstem. Of course, you cannot get the vessel here completely away because there is no space. What should you do? What should you do? You have no chance. You can just clip the basilar, but it's also not a good idea regarding outcome. So then I put some Teflon more, and I was really surprised. He's also more than 8 years after surgery, and he has still no pain without any medication. So it's surprising because there's still a big compression, but the proximal part is not in direct contact. So this might be enough in this case. So sometimes when we have no vascular compression, we make also a rhizotomy. That means we cut 1/3. So there was a patient with pain in the lower distribution of the trigeminal nerve with multiple sclerosis. You see the lower third, we just cut, coagulate. So it's a rhizotomy of the lower third corresponding to the mandibular nerve. And she was free of symptoms. What is with venous sacrifice? Can we sacrifice this vein? You have a severe compression here at the entrance of the nerve. So this is interesting. The venous compression frequently are not at the exit zone and the brainstem, but peripheral. And they are really the cause of the problem. So in this case, I just coagulated the vessel, and you see the severe grooving, what the vessel did to the nerve. And afterwards, he improved very much. But we have to be careful. We had one case, in this, you see here also the vein make a severe compression, and I coagulated this vessel, and then the lady had severe problems. You see the swelling of the brain, of the cerebellum. She has a little bit bleeding here, so congestion, bleeding. But fortunately, this cerebellum did not explode. Had just a little bit dizziness, double vision, and she did not feel well. But fortunately, even after some days, it did not bleed massively. And then after a while, she recovered. Now she's okay. She has no trigeminal neuralgia, but it shows how risky it is to take a vein when you don't have collaterals. So it's very important when you consider cutting of a vein, you have to look, is there any collateral? Yeah, similar case. You see here, there is a trigeminal, here is this loop. So now I take a 45-degree endoscope and I look. Here is a compressing vessel of the trigeminal nerve at the entrance into Meckel's cave. And you see here, the vein comes here, but makes a second loop and goes here to the superior petrosal vein when it goes to the petrosal sinus. So I check again. It's the same vein. One branch goes out here and the other one makes a loop and goes to superior petrosal vein. So when you see there is a collateral of these veins, then nowadays I dare to coagulate it. But if I don't see, I would never do it again, because I had this one patient where we had almost a catastrophe. So the veins are unpredictable. That's why you always have to check. So I think we have 1 hour. I could talk many hours more, but I think it's enough. Otherwise, it becomes too much and you will be tired. I think I stop now. We had only a hemifacial spasm left where we use the endoscope very frequently, but maybe we can cover this topic a little bit later. So thank you for attention, and I'm open for questions.
Thank you very, very much, sir. Sir, you can take as much time as you would like because everyone was so much engaged with the lecture. I've been seeing that everyone was watching it very thoroughly, sir. But I believe that it will be great. It will be huge honor. It will be very lucky of us if we can invite you again for more of your videos because those were so excellent, sir. Thank you so much.
Great pleasure.
And sir, I think there were a couple of questions over here, and most of the time, sir, because I guess the lecture was so elaborate, you have clarified many of those questions that have been asked in the chat box. But there was a question on regarding irrigation, sir. I think that you always talk about irrigation, and there was a question about thermal injury, how to avoid thermal injury. So these are such some of the questions that I could see in the chat box. And somebody asked, Dr. Kalim Iftikhar has asked that can, with the help of endoscope, can we somehow avoid drilling the internal auditory canal? Is it possible that endoscope may help us in avoiding drilling of the internal auditory canal?
Yes, you can do. I did in some cases, but nowadays usually I do it under the microscope because when you drill, always some bone dust is flowing around and it might go to the lens, but it can be happen. When the last piece has to be drilled, which I don't see very well nicely with a microscope, then I take the endoscope and drill the last piece. But from the beginning, I see there's no advantage and it's faster and my hands safer. I do it under the microscope.
Great, sir. And there was another question, again regarding more of the less irrigation. And somebody has asked that I have seen people using water medium, which improve visualization slightly, zooming the field, and will also take care of the heating issues if the water is circulated. We need your kind suggestions regarding this.
So I irrigate just with a syringe. My assistant is irrigating over the lens. That is what I use. But of course, there are many ways. It's important that the nerve does not become dry. It should always be wet because the heat may cause thermal injury to the nerve. That you should be considered.
Sir, there's also a question from Dr. Ibrahim. He's saying that after how long did you plan the facial nerve reconstruction after facial palsy of post-operative facial nerve damage?
So that depends. The case where I have shown, I do it immediately because I see the nerve is not in continuity. Then of course you reconstruct. So if you see during surgery the nerve is cut or is destroyed by the tumor, then we make immediate reconstruction. When I have a vestibular schwannoma, where I have a patient with a facial palsy after surgery, although I preserved the nerve and it did not improve to a sufficient level, then we would wait 1 year at least to see whether the nerve is recovering. And in most of the cases, and nowadays, when we have a facial nerve after dissection, we are sure it is not interrupted and there is improvement. Before, when I was a resident, we had no monitoring for the facial nerve, and then frequently the facial nerve was completely lost, and then we make a lot of hypoglossal facial transfers. But nowadays, it's very, very rare that we need it. So we wait 1 year when we don't know whether the nerve is in continuity or not. When we see it's cut, of course, we do it immediately.
Great, sir. Sir, there is also some Dr. Kumar. He wants to know if there's any effective technique to preserve facial nerve in your kind view.
The technique to preserve?
Yes.
The most important thing is to identify the nerve. So in the vestibular schwannoma, I open the canal first and find the distal part of the nerve. There is always, the topography is pretty sure. The facial nerve is always in the upper frontal part of the internal auditory canal. So you find it always. And then you have to find at the brainstem. And the larger tumors sometimes difficult. But I always dissect from below to go above. So like Majid Sami has recommended it, and I learned it from him, to come from below, go up, and then you find the nerve at the brainstem. And at this area, usually the nerve is not very adherent. The adherent part comes when the nerve turns from the brainstem into the cisternal segment and then into the internal canal. At the entrance in the internal auditory canal, there is a part which is most sticky. And then you have to decide, when you see the nerve is easily dissectable, you have no monitoring response, then I go for a total resection. But when I have these pathological trains, typical, this is a noise that is, the nerve is complaining, oh, please let me alone. When this happens 2 or 3 times, I stop, because when you continue, you will have facial palsy. And my aim is always to preserve it. Even if you have to leave a remnant, even if it's growing, in many patients it's not growing, and even if it's growing, you can give radiation, but try to avoid giving a patient a weak face. That is not nice.
Thank you very, very much, sir. Sir, there's also another question that has just popped in. Sir, Dr. Vineet Dinishan wants to know, great talk, sir. Thank you so much. How do you repair the facial nerve? Suture versus the use of glue?
Yeah, as I have shown in this case, when you have an intracranial, you cannot make a suture. When you make a hypoglossal facial transfer peripheral, you can suture it, and I make epidural sutures. But intracranial, there is no good layer to make a suture, so I always glue. I just put some gel foam, and it's very important that the nerves are not like this, but they should be stump on stump. And then I put some gel foam to keep the position. I make glue around. And after 7 or 10 days, the glue is resorbed, but then already you have adhesions from the healing.
Great, sir. So Dr. Hatem is asking, isn't it risky to drill the IC before decompressing the tumors in large schwannomas?
Is it what? To open?
And sir, isn't it risky to drill the internal auditory canal before decompressing the tumors in large schwannomas?
No, no. It's only necessary that you decompress when the tumor is laying on the posterior wall of the internal auditory canal, then you cannot reach it. But most tumors, at least the size what we have in Germany, they grow away and you have access to this. Then I would first open it. If you have a huge tumor, it's covering, of course, then you have to first remove the tumor. But I always do it at the beginning to open the canal. When you make it later on, you spill all the bone dust and all this big cavity. In the beginning, everything is closed. The arachnoid is still there, so you don't disseminate all the bone dust to the whole skull or the subarachnoid space. So I think it's better you do it at the beginning.
Great, sir. Sir, there is, I think we are, sir, actually
These
everyone is
two questions.
Yeah, exactly, sir. Sir, I think he has got a longer question. Dr. Evin Tahir.
Do you prefer endoscope on a rigid frame or assistant holding it? So it's also depending. So in pituitary surgery or craniopharyngiomas, chordoma, so any endonasal stuff, I have the assistant holding the scope. When I do it for vestibular schwannoma, it depends. If my assistant had experience to hold it, I give it to him. If he has no experience, I fix it. So it depends from this situation. And the other question is, with endoscope, do you still have a drill? Do you still have to drill internal auditory canal, or can be avoided? No, I would never avoid it. Even if you can see in this area, you want the idea for drilling of the internal auditory canal is to decompress. So when I drill, I always make 180 degrees unroofing of the canal, so I have no pressure. When you leave it and you go in with your instruments, you squeeze the nerves even more. That is not good. So first you decompress the bony, 180 degrees unroofing, then you open the intrameatal dura, and then you can dissect because you have space. You can mobilize the tumor away. So I would never recommend that you don't drill anymore.
Sir, there's a long question over there from Dr. Evin Tahir, sir. Thank you very much, sir. Very enjoyable lecture and discussion. His first question is, how to protect damage against the cranial nerves and other structures at the endoscopic blind areas?
Yeah, that is a problem. That is really a problem. When you go very deep and you have nerves, then an option is that you have an exoscope which shows you the surgical field. When the endoscope is in, you can see it. But this is a little bit cumbersome because you have to watch at the same time 2 monitors. So at least most of males are not capable to watch 2 different stories. but you can use monitoring. So what I have, all the nerves have monitoring. So when I touch a nerve and it's a motoric nerve, then immediately I would have some response. So I think the best way to avoid this is to be careful when you introduce the endoscope, then you don't move much and you listen to your monitoring.
Great, sir. And he has got another question too. How to arrange instrumentation for the beginner? What do we exactly need? Beginner in endoscopic assisted surgery. And can you show us some intraoperative photos of how you handle the endoscope when you are inside the field?
So I think you should just take an endoscope. When you don't have an endoscope in your institution, you ask the ENT. The ENTs have a lot of endoscopes. And then you take the endoscope just for observation during your routine case where you don't need it. Just to be familiar. It's very important that you have the right balance, that you don't turn the camera in the wrong direction, because when you move in, you see the image goes to the right side. And the camera has to be always looking up, that it has the same orientation what you have with a microscope. That's just very important. So you should use it when you don't need it, just to be familiar with it. And then you start with simple cases. You take an easy case where you have a tumor remnant which can be removed under the microscope, but you just do it to train how it is under the endoscope. And then when you become more familiar, you make more difficult cases.
Thank you so much, sir. Sir, I think the questions keep on coming, sir. Sir, there are 2 more questions over here in the chat box, sir. Sir, this one is from Dr. Vineet. He wants to ask, do you have any indication for an extended retrosigmoidal approach?
Extended? Yeah, when you have tumor which goes to the middle cranial fossa, you can drill the suprameatal tubercle, and then you get access to this area. And sometimes when you see the tumor goes more down, you can extend it to a far lateral approach. So it's always depending where you want to go and which area you want to dissect. You can open the tent, then you can go more to the temporomesial area. So there are many options, depending always where you want to go, and you can extend this approach in this direction. So it's a tailored approach. It's not a fixed approach like formally we do always this with this. No, we look to the region and then we see how much can we get from the simple approach. And when we have a problem to get it, then we can make an extension.
Thank you so much, sir. Sir, Doctor, I think this is the final question over here. Sir, Dr. Kumar wants to ask, sir, do you have any suggestions for cystic schwannomas?
Yeah, cystic schwannomas, you have to be especially careful because they are more sticky to the structures, to the nerves and brain stem. So you have to be very, very careful. Sometimes it's possible to make a good resection of the cystic part as well. We just had a case some months ago. I was surprised I could dissect it from the brain stem. Although it was firmly attached, I was always a good plane. I never entered the pia, could preserve all the veins. So always we try to get as much out as we can. But when you see there is sticky to the nerves, like in this Kuwaiti girl, then of course better you stop before you do any damage.
Thank
you.
Always
depending on the anatomy and what the monitoring says.
Great, sir. Thank you so much, sir. So the lecture was so much elaborate, and I think that there are so many messages, and everyone is really, really admiring, appreciating you, sir. We are all huge fans of yours, and there's a message from Dr. Alzan, and he's saying that, sir, we are not tired. You can have us here for hours, and we will be listening to you for several more hours. So thank you so much, and I think we have taken a lot of time from you during the discussion and during the class. So thank you so much. We owe you a huge thanks for all of this huge favor.
My great pleasure. I'm happy to come back.
So it's great, sir. Thank you very, very much, sir. I will be so honored to contact you again and request you again, sir. Thank you so much. It means so much to us.
Thank you so much. I wish you a nice evening and hope to see you soon again. Bye-bye.
Bye. Thank you so much, sir. Thanks very much. Thank you everyone for joining us today, and I hope you had a wonderful learning experience. And again, thank you very, very much, Dr. Ahmed Fawad Pizad. Walaikum salam, Dr. Ahmed, and thank you very, very much. Yes, and a big thanks to the Afghanistan Neurosurgical Society again. Thank you so much. It's great to have you here with us to attend this lecture. And here is the link to the quiz. Just submit the quiz, and you will be able to have your own certificate emailed directly to you. It is a simple quiz, and again, the grading doesn't matter in this quiz. It is just for your own practice and learning. So just fill the quiz and submit it, and you will have your certificate emailed directly to you. Dr. Faiz, thank you very, very much. Thank you for attending the webinar, and all of you, please keep yourself updated through my WhatsApp groups. I think you are all in the WhatsApp group, and also please keep visiting newsneuro.xyz for more of my initiatives and the book we are going to launch next month, inshallah. In a couple of months, I'm going to launch a very wonderful book with Professor Louise Boba. This book will be available in Pakistan in a couple of months, inshallah, and it will then be available internationally. I will keep you all updated. Thank you very much, Dr. Seprabex. Thank you so much for joining in. I think it's fun to learn together. And if you have more comments or suggestions, or if there is any lecture that you wish me to organize, please do leave it in the chat box, and I will be so happy to have you all here with us again, and we can learn again from the wonderful masters. So if there is any particular topic that you wish me to organize a webinar on, please do share it with me. So again, I hope that all of you have received the link to the quiz. It is in the chat box. So you just have to submit it, and in order to receive your attender certificate, and it will be emailed to you immediately after submission of your quiz. And this is again the link to the quiz and to my WhatsApp group. And this is my website. Please do visit it also. Thank you very much, Dr. Khairuddin. I hope you have all received the quiz link. If you have opened the quiz link, I think that we can log off. Okay, everyone, thank you so much again for joining in, and I wish you a wonderful rest of the day wherever you are, and please to join me again after 8 days on 32nd of January, 32nd of December. Professor Michael Lawton will be delivering a lecture with us on news. Let me share the link with you. It will be held on 22nd December. Let me share you the link. Professor Michael Lawton has already delivered a lecture with us on vascular neurosurgery webinar series. He will be talking about the cerebral cuboidal malformation on the 22nd of December at 12:30 p.m. Mountain Time, 2:30 p.m. ET, and 11:40 p.m. Pakistan time, and 7:40 p.m. CET. I share you the registration link to Professor Michael Lawton's lecture. So here's the link. You can just click on it and get registered for Professor Lawton's lecture next. So again, thank you very much, and time to log off. Have a wonderful rest of the day. Goodbye. Thank you.